Recording in
Good
progress.
evening, everyone. I'm Eugene from Hong Kong, and welcome today all of you to join our IPNA Clinical Practice webinar. Our topic for today is the International Expert Consensus Statement on the Diagnosis and Management of a Congenital Nephrotic Diabetes Insipidus, a rare but very, very important disease, and we need so much advice on the management. And today we are very pleased to have Eleanor, our great friends from ITNA, who works with me together in the Professor Education Committee. She's the full professor in the Amsterdam University Medical Center, and she has been focused her research on unraveling disease mechanism and finding the best treatments for children with genetic kidney disorder and kidney failure throughout her career. And we also have Professor Nina Knowles, and she is the Emeritus Professor from the Department of Genetics at the University Medical Centers of Groningen at the Netherlands. So she has been the honorary member of the Dutch Society of Clinical Genetics as recognition of her major contributions to clinical genetics to professionalization of the society. We must mention that her major research effort focuses on the identification of genes on inherited renal disorder and also the pathophysiology to find clues for treatments. So we are very, very pleased to put both of you today. And just before we start the webinar, I must share with you that we have recently introduced a very important utility in our Zoom platform that is the Wordly. And as some of you may have used, it includes almost 50 languages for the live translation, which is really helpful. I tried myself with the Chinese and it's excellent. So feel free to use that. And apart from that, we also want to introduce you and remind you to renew the membership of IPNA in 2026. And very importantly, we want to promote there is a free IPNA membership for the low income as well as the lower middle income countries. So do join us through the internet and our website and find more information about all our benefits. So we are about to start, and before that, I would like to remind you there will be a Q&A section at the end of this webinar. Just feel free to leave it at our Q&A chat box, and we look forward to a very fruitful discussion after the presentation. So thank you, Eleanor. Thank you, Nina. And the floor is yours. Eleanor, we can't hear you yet. I think you have muted.
Perfect. Can you see my screen now?
Yes, Eleanor.
Okay, perfect.
But it's not yet in presentation mode, Elaine.
Yeah, I'm trying to put it in the presentation mode. Yeah, now it is, I think. Yeah, okay, perfect. So, hello, everybody. Thank you very much for giving us an opportunity to present this consensus statement on the diagnosis and management of congenital nephrogenic diabetes insipidus. It's a great pleasure to present it. It was a great work to do it. It was a lot of work, and finally we are happy that the work is done, is published. So we will discuss a guideline, and you can also read it in the Nature Review Nephrology. So the disease we are going to discuss today is called nephrogenic diabetes insipidus, or NDI. And it might be that the name of the disease will be changed, because our colleagues endocrinologists prefer a different name for the central diabetes insipidus, which is due to the deficiency of the hormone of arginine vasopressin. So they prefer to call central NDI the deficiency of vasopressin, and they like to call nephrogenic DI as a resistance to vasopressin. However, in our nephrologic community, we still like the traditional name NDI, and so I will use this name during this presentation. So as you can see on this slide, the disease is caused by the resistance of cortical collecting duct to the hormone AVP or arginine vasopressin, which acts through its receptor vasopressin 2, which results in the cascade of the events resulting in the formation of cyclic AMP, activating protein kinase A, and this in turn phosphorylates in the aquaporin 2 water channel, and insertion of this channel at the apical membrane of the principal cells of the cortical collecting duct, allowing water reabsorption through these cells from the tubular lumen to the interstitium, and this results in the concentration of urine. So as you might note, in the majority of the patient, the disease is caused by mutations in the receptor encoded by the AVP-R2 gene, which is located on the X chromosome. And these mutations are found in about 90% of all patients. I'm trying to switch on my pointer. Yeah. So, and in the minority of the patients, and it's about 10% of the patient, the disease is caused by mutations in the aquaporin 2 gene, encoding aquaporin 2 water channel. And in the majority of these patients, the disease is autosomal recessive. However, there are some patients in whom the disease is inherited in autosomal dominant pattern. So, polyuric patients were discussed many centuries ago, and actually the first century before Christ, the first mention of diabetes, which means pass or run through, can be found. And the first description of the disease as an entity was done at the end of the 19th century in three-generation family. And finally, the term of nephrogenic diabetes insipidus contrasting central diabetes insipidus was published in 1943 in this publication in Annals of Internal Medicine. And that was the time that the disease was known as a clear entity. So the genetic basis of the disease was described in 1992 by our speaker of today, Professor Nina Knurs, together with Leo Moniz and Peter Deans. They described for the first time in this publication in Nature Genetics mutations in AVP-R2 gene. And 1 year later, Daniel Bichet in Canada also published mutations in the same gene in the North American population. And finally, a year later, two publications in Science described the mutations in aquaporin 2 water channel, completing the description of the genetic basis of the disease, which is very important to genotype these patients and understanding their genetic background. So, although the disease is well known, it's a rare disorder. And actually, I'm not sure about the prevalence of the disease, and it's slightly different in different populations. And because the disease is not so well known, a couple of years ago, the European Reference Network of Rare Kidney Diseases decided to establish an expert group to formulate recommendations on the diagnosis and treatment of this disorder. So this group consisted of one geneticist, which is Nina, 6 pediatric and 5 adult nephrologists, 1 urologist, and 1 patient representative. We were supported by the ERCNet team, and we had also a panel of 30 experts from ERCNet and also European Society of Pediatric Nephrology experts in tubulopathies who assessed our recommendation and also voted using the Delphi methodology. So we follow the standard methodology to develop guidelines and consensus statements, starting from the formulation of the questions, studying literature, formulating recommendations, explaining them, the appraisal, and finally the publication. Each recommendation was graded following the recommendations of the American Academy of Pediatrics, depending on the level of evidence. And obviously for the rare disease such as NDI, we did not have a lot of randomized control studies, so most of the recommendations were level C or D. And also the recommendations were graded dependent on the benefit or harm to the patients, and that was also expert-based. So altogether, we formulated 36 PICO questions. The literature was searched starting from 1950, the time when the disease was described. We included their prospective trials, which were not so many, but also observational studies, registry data, and also summary of case series. We excluded the animal data except when it concerned the development of new treatments. And altogether, we retrieved 230 results, and finally, 190 papers were used to formulate the recommendations. So we started the paper to describe the signs and symptoms at presentations of NDI patients. And as you can see from this table, most of the signs are the signs of the dehydration. So many patients present with failure to thrive, poor growth, dry skin, low skin turgor, sunken eyeballs, sunken abdomen. But it's also important to realize that some patients might present with neurological symptoms of dehydration and hyponatremia, which can be irritability, fever, or even seizures. And obviously, most of the patients have thirst, polyuria, which is the main disease feature, vomiting, and poor appetite. And here you can see the picture of the patient at diagnosis, which really looks as a young boy looking like an old man. And this is the same patient after rehydration. But these days, we don't see so many of such severely dehydrated patients, fortunately. So we made also the list of the differential diagnosis of NDI, and the main diseases we have think of, especially in adult patients, is the acquired forms of NDI. Many adult patients are treated with lithium because of the psychiatric disorders, and lithium can cause NDI. Central diabetes insipidus is AVP deficiency. Some patients have primary polydipsia. And poor control diabetes obviously also can result in polyuria and polydipsia. And then we have a large group of renal tubulopathies, mostly inherited, but sometimes also acquired. And these diseases also can cause polyuria and polydipsia and can be distinguished by biochemical or genetic diagnosis. So let's come to our recommendations. And here you see the types of the 36 recommendations we are going to discuss. So let's start with a diagnostic approach. But before we are doing that, I would like to offer you the first poll questions to keep you awake. So the first question is, which diagnostic approach is recommended first when nephrogenic diabetes insipidus is suspected in a child? And there we have options: A, water deprivation test; B, DDIVP test. DDIVP is a synthetic analog of arginine vasopressin; C, genetic testing; and D, plasma copeptin measurement. And please remember which is the first diagnostic test would you apply if you suspect a patient with NDI. So I think we can proceed to voting. Yes, can you please open the poll? Okay, I think people can see the poll now, so please vote. I think we can close the poll now. I hope I can see the results. Okay, nice. So the results are really very, very random. So many people suggest doing water deprivation test, DDIVP test, genetic testing, and plasma copeptine. I think, Nina, you have a job to do to discuss. Eventually, all options are possible, but Nina will go on with the slides to explain why in our recommendation, we actually, when possible, we suggested to do genetics first. I have some difficulties to move my slide now. I hope it will work. Yes, so Nina, the floor is yours.
Thank you very much,
I will switch off my microphone.
Thank you very much, Elena, for this introduction. And indeed, one of our first recommendations is actually to start a diagnostic process with genetic testing in all patients that do have clinical and biochemical symptoms of NDI. And we do this because the genetic test will definitely give you a diagnosis, will also answer a question whether it's the X-linked form or the dominant form or the recessive form. So that's very important, of course, for also the genetic counseling and the risk of another child having NDI. And it is quite an easy test nowadays. We can do this within a few days nowadays to find an answer to the genetic test. And it's also relatively cheap by now. Of course, we realize that in the world, not everyone has access to diagnostic testing. And there are also other ways of finding a diagnosis, and Elena will talk about that in a few minutes. But again, if you have access to genetic testing, we think it's best to start a diagnostic process with that tests. If you have, for instance, a young boy, a just born boy, of a mother of whom you know that it's a carrier of an AVPR2 mutation, you can perform a genetic test directly in umbilical cord blood. And this will give you an immediate diagnosis. That is, of course, very important to further manage this child. It's very important that you do the genetic testing in a laboratory that is accredited for diagnostic genetic testing and not in every research lab that you might know. So that's important to really be sure that the diagnostic testing is done in the right way. And if possible, nowadays we make use of a gene panel, a multi-gene panel, that's based on what's called massive parallel sequencing. You also might know this as next generation sequencing. That includes at least, of course, the AVPR2 gene and the aquaporin-2 gene for NDI, but also the arginine vasopressin gene, because sometimes it's difficult to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus. It's also important that this multi-gene panel is able to identify copy number variants in these genes, because we know that copy number variants are also frequently involved in causing NDI. And again, we now have these tests available in many countries, and it's relatively cheap, and it gives you a final diagnosis, which is important. And this will also then it will not be necessary to perform other tests that might be more intensive for the patients to undergo. Can I have the next slide, Elena? So as said, it gives you an early and definite diagnosis with important implications for management and outcome. And it also prevents that, if the diagnosis is not recognized, we sometimes see these severe hypertonic dehydration periods. And that can, if you do an early genetic diagnosis, you might prevent that by starting the management immediately. As said, other diagnostic procedures are no longer necessary. It can also help to identify patients that have partial NDI, and as said, these are sometimes very difficult to differentiate from the central form of NDI, and I'll have some examples in one of the next slides. It's very important to have this genetic diagnosis for genetic counseling and family planning, and it will also give you an opportunity to do pre-symptomatic testing in family members at risk. So these are all very important reasons to start early genetic testings in these kids that you suspect having NDI. Next slide, please. So this is a table of pathogenic arginine vasopressin receptor 2 variants that have been shown to give a partial nephrogenic diabetes insipidus. These are children or sometimes even adolescents that manifest NDI much later in childhood. They do not have a failure to thrive, which we of course often see in these very severe NDI cases. And when you give them DDAVP, they are able to concentrate urine in response to DDAVP, and sometimes also if you do a water deprivation test, they give some concentration of urine, but to a lesser extent than unaffected individuals. And as said, sometimes it's very difficult to differentiate these kids based on, for instance, DDAVP administration tests from the central DI. And that's why we prefer to do genetic testing in these children. Please go on, Elena. The next slide is dealing with females that have NDI. And of course, females having nephrogenic diabetes insipidus, immediately you think, well, this might be a dominant NDI or a recessive NDI, and not in X-linked NDI, because we, of course, think that carriers of AVPR2 mutations do not show a phenotype. However, this is not always the case. So X-linked NDI is usually very severe in males, and in the majority of female carriers, there's no phenotype or only a very mild phenotype. However, we do know that in about 10% of female carriers, that they show an almost complete NDI phenotype. And in this slide, you see an example of a pedigree where you see that one boy has a pathogenic variant in AVPR2 and is showing, of course, the complete NDI phenotype. His mother, who is a carrier, has mild concentration defects, and she does have two daughters from another father, and she's given the mutations to both of her daughters, who are also female carriers. One of them does not show any phenotype. One of them has no urinary concentration defect, so no phenotype, and the other shows a complete NDI phenotype. And this is, of course, very puzzling. But when you click, Elena, to the next click, please, we see how this actually works. So as you might know, in females, very early during development, very early after conception, a phenomenon occurs which is called X inactivation. This means that from both axes of the females, one of those axes is inactivated. And because this is a rather random process, this means that when you have cell division, in one cell, let's say the previously maternal X is inactivated, whereas in the other cell, the previously paternal X is inactivated. From that time on, mitosis goes on. That means that all the descendants of these cells will have exactly the same inactivation phenotype as let's say, the mother cell. So this means that in the normal situation, in a random X inactivation situation, in 50% of the cells, the original paternal X is inactivated, whereas in the other 50%, the original maternal X is inactivated. So there is a sort of compensation, and that means that most of these females with random X inactivation do not show a phenotype. However, we know that X inactivation is sometimes very skewed. And that can mean that in the majority of the cells, let's say in 90% of the cells, the X chromosome, which does not carry the mutation, so the normal X chromosome is inactivated, and let's say the other chromosome, which is carrying the mutant, is active in the majority of cells. And in that sense, in that case, the latter case, females will have a phenotype. So the reason for a phenotype in NDI females, carriers of AVP02 mutations, is skewed X inactivation. And in fact, in this family, we have shown a skewed inactivation indeed in the carrier that showed a complete NDI phenotype. Next slide, please. So I hand over again to Elena, who will tell you if genetic testing is not available, what to do then.
Thank you very much, Nina. So coming back to the listen to the poll, I will review all options which were there, and actually you were all right. But maybe the order of the tests can be different, and obviously in the countries which do have access to quick and reliable genetic testing, this is a test of choice. But if genetic testing is unavailable, and sometimes it still can be inconclusive, we can do other tests. And one of the tests is a very elegant test, is to measure plasma copeptin. Plasma copeptin is a glycopeptide, which is a C-terminal part of the AVP pre-pro hormone. And why do we use it? Because the AVP itself is difficult to measure. It's also unstable. But this part of the hormone is released in the equimolar ratio with AVP, and therefore we can use it as a surrogate measurement of the AVP. So in adult population, it was very nicely demonstrated, and the paper was published in the New England Journal of Medicine, that the baseline levels are above 21.4 picomole per liter, are really a reliable diagnostic test for the nephrogenic diabetes insipidus in adult patients. Unfortunately, we don't have these cutoff levels yet in children, but obviously also children presenting with NDI have high copeptin levels. So this is a very good test, not yet validated for children. So the DDAVP test is also diagnostic to distinguish between central and nephrogenic diabetes insipidus, and we have a clear cutoff values diagnostic for nephrogenic diabetes insipidus. And the protocols of this test also can be found as a supplementary materials of the paper. However, as Nina told, some patients with milder mutations might respond to DDIVP, although not completely. So here you have to be very careful with interpretation of this data if you have some doubts. And then we have a water deprivation test. And here we had a lot of discussion about this test in our group. And finally, the conclusion, the recommendation is to perform this test only in selected patients with polyuria of unclear etiology. And this is because performing water deprivation in patients with nephrogenic diabetes insipidus can be dangerous because it can lead to severe dehydration of the patients and also to a lot of suffering of the patients who suffer from severe thirst. And when these patients are not allowed to drink water, it really results in severe suffering. So this test should be performed under constant medical supervision. It should be aimed at differentiation between diabetic insipidus and habitual polydipsia. And the interpretation of the results, and this is also another reason not to perform this test in routine, for the diagnosis of NDI, because in patients who have polydipsia, who are drinking a lot, the expression of the aquaporin 2 is reduced, And this can result in reduced urine concentration response after the administration of the DDIVP, making it difficult still to distinguish between habitual polydipsia and patients with partial diabetes insipidus. I'm sorry, there is a small delay in switching off my slides, and that's why each time we have to wait a little bit. So this is actually the diagnostic flowchart, which is published in the paper, and I think it's very helpful to follow when you have a patient presenting with polyuria or polydipsia, failure to thrive, and hypernatremic dehydration. So as Nina has said, when you have a patient with positive family history, it is advisable to perform direct genetic testing. And when you have a boy of the mother carrier of the mutation in the X-linked nephrogenic diabetes insipidus, you should perform genetic testing immediately in the cord blood. If genetic testing or immediate genetic testing is not available, we go on with the diagnostic algorithm, and the test to do is to measure urine osmolality and serum sodium. And if you have a patient with diluted urine despite of the dehydration, and the serum sodium is increased, the diagnosis of diabetes insipidus is very likely. And in these patients, when you don't have the possibility to perform genetic testing, or you have to wait a long time for the results, you can perform the DIVP test in children. And when there is no response, the diagnosis of NDI can be made, and you still should confirm it by genetic testing. And in adults, measurement of the copeptin levels recommended. And when these levels are high above the cutoff value, again, the diagnosis of DI is probable and genetic tests should be performed. And when the levels of copeptin are low, or the patient is not responding to the DDIVP, the patient is probably likely to have the central diabetes insipidus, and also this should ideally be confirmed genetically. If the patient with dehydration has concentrated urine, then the diagnosis of NDI is highly unlikely. And when the urine is diluted, but serum sodium is low normal, or the patient is hyponatremic, then primary polydipsia should be considered. And these are actually the patients where water deprivation test can be performed under medical supervision. So let's move now to the treatment recommendations. And we have recommendations separately for children and for adults, but because we are the pediatric association, I would mainly concentrate in children recommendation. But also before doing that, we will have another poll question. And the question is, which of the following is the initial therapeutic step in patients with NDI? And the A option is reduce dietary solute load. B, start indomethacin. C, increase water intake. And D, start the thiazide diuretic. And again, the question is, what is the first therapeutic step? And we can show the poll and allow you to vote. Please show the poll for the question 2. Okay, I think we can close the poll and show the results. Okay, very, very nice. I think that the majority has chosen the correct answer, which is reduce the dietary solute load as a first therapeutic step in these patients. So we can close the poll and go on with the slides. I'm sorry for this delay.
Maybe close your pointer, Elena.
Yeah, it was just working. Yeah. Okay, so these are our recommendations. Obviously, patients with NDI should free access to fluids, and when they have breastfeeding, breastfeeding is actually very low in solute, so they continue breastfeeding, and it's very important to guarantee their sufficient caloric intake. So it's very important to consider initiating tube feeding in infantile children who experience recurrent episodes of vomiting and dehydration, especially when they have poor growth, because we still see quite a lot of NDI patients presenting with severe growth retardation. Sometimes very difficult to treat them for catching up growth. So don't wait too long with initiating tube feeding in these patients. And then their initial therapeutic step is to provide nutrition with a low renal sodium load, and there is some recommended values, and we also provide their formula to calculate the renal sodium load in the paper. And then it's very important to involve the dietitian to develop and regularly review the feeding plan in collaboration with the family. So the medical treatment, the first step is starting the thiazide and prostaglandin synthesis inhibitor. So people who voted for that were completely right. Also, the first step is to reduce the sodium load. And patients who develop hypokalemia can be treated with amiloride on top of thiazide diuretics. So it's very important when you start the treatment to evaluate the efficacy, and the efficacy is your urine output in the patient. So it's important to evaluate it, and obviously the weight gain and the growth of the patient, but you really should monitor the urine output before you start treatment and after treatment initiation. And you should also evaluate the treatment based on their efficacy and eventual side effects, as for example, hypokalemia. So we had also several recommendations regarding the urological follow-up of the patients, because patients with severe polyuria can develop their dilatation of the urinary tract and also bladder dysfunction. So it's important to perform their kidney ultrasound at least once in every 2 years to monitor these complications. And also, patients should be followed by a multidisciplinary team consisting of pediatric nephrologist, dietitian, psychologist, because this patient can have psychological problems and also school problems, social work, and also urologists. So in adults, I think for us as pediatric nephrologists, it's especially important to perform the careful transition to the adult specialist who is experienced in the disorder, who will also review the diet, the medical treatment. Most of the adult patients discontinue diuretics and discontinue prostaglandin synthesis inhibitors. And we also had the notion of our adult colleagues that the signs and polyuria in these patients decrease when patients are getting older. And this results in the fact that they might need less strict diet and when they become older. But I think for us as pediatric nephrologists, the most important thing is to find a good adult nephrologist experienced in the disease when we transfer our patients to the adult clinics. So we formulated also recommendations for the minimum follow-up frequency, and the rule here, the younger is the child, the more frequent he or she should be monitored. Another important recommendation we formulated were on the emergency management. And here again, I would like to ask our last poll question regarding the emergency management. And the question is, in patients with NDI having the hypernatremic dehydration, which approach is recommended for rehydration of this patient? And the answer options are A, slow correction of serum sodium with isotonic saline, B, oral rehydration with ORS, C, slow correction of sodium using Ringer lactate solution, and D, intravenous rehydration with 5% dextrose or glucose solution. So please show their poll and you can vote. Okay, I think we can close the poll and see the results. Okay, so this is something that I could expect, and this is maybe very important that I'll discuss in the next slide to you, because actually the correct answer in this to this question is option D. We should rehydrate these patients with intravenous fluid do not containing sodium, and this is very counterintuitive, and this is not what we used in the medical school in rehydrating patients with hypertonic dehydration, but NDI is really an exception of the rule in this regard. So we can close the poll and I will go on with my slide. So the recommendation for emergency management is to use water with dextrose or glucose for intravenous rehydration. And this is because this patient cannot concentrate urine. So the more osmotic load and sodium containing solutions are offering this patient osmotic load, the more osmotic load you offer to these patients, the more diuresis you will stimulate. So actually, counterintuitively, if you will give this patient solution containing sodium, they will pee more and not less, and this will aggravate the hypertonic dehydration, contrary to all other patients having the hypertonic dehydration. And so what we should do, we should calculate the initial rate of fluid administration to avoid a decrease in serum sodium above 8 millimole per liter per day, just as we do for the other patients with hypernatremic dehydration. And so when you start rehydrating the patients, you start with a normal fluid administration rate, you monitor their fluid balance, and you monitor their serum sodium, so that is not decreasing too fast. These patients really should be rehydrated very careful. We should clearly, very closely observe their neurological condition, fluid balance, body weight, and serum electrolytes. And we should adapt the rate of the fluid administration very carefully according to these values. And therefore, these patients should be best treated in the specialized centers with experience of the disease. And also when NDI patients are undergoing anesthesia, surgery, or other situations of acute illness that carries the risk of acute hypernatremia and dehydration, they should be closely monitored for fluid balance and electrolytes. And we should warn our colleagues that they should not receive fluids containing sodium. This is very, very important. So let's go next to the next slide. Okay, yeah, and this is emergency plan for each patient that we propose, that we highly recommended that patient carry this information with them in case of unexpected emergencies. And in this case, the name of the patient has to be mentioned. And then this recommendation not to use saline or not to use solutions containing sodium should be prescribed, and patient should be warned about this recommendation and actually using this cell line for fluid resuscitation is only allowed in the situation of acute blood loss or shock, and then we should switch back to their low salt or no salt solution. And ideally, patient always carry a number of their nephrologist or another specialist who can recommend in case of the emergencies. Okay, then I switch off my microphone and I give the word back to Nina. Nina, please, and the floor is yours again.
Thank you, Elena. So please, one of the recommendations also involves counseling and family planning, to which we will move now. So, of course, as you know, in any genetic disease, genetic counseling of the parents, or sometimes also of the affected children themselves, is very important. So we strongly recommend this genetic counseling, preferably done by a clinical geneticist, maybe together with a pediatric nephrologist or a nephrologist, of parents of affected children, but also of young adults who have the disease, or like the females who are heterozygotes for the AVPR2 mutations, or sometimes also when you know that they are carrying an aquaporin 2 pathogenic variant as well. And then maybe also those in whom you have not done a genetic test yet, but who are at risk of being heterozygotes, so being a carrier. So what we do in this counseling is give information about the inheritance of the possible recurrence risks. We tell them what the implications of a genetic test might have for family planning, including reproductive options, and such as prenatal diagnosis or pre-implantation genetic testing. And if there are patients with X-linked or dominant NDI, of course, information about implications for family members are also discussed. And we advise them to inform these family members and also give these family members the option to do a genetic test themselves. Next, please. So as said, reproductive options are prenatal testing. That means that you do a test while there is already a pregnancy going on. And of course, if you would then find the mutation by doing chorionic villus sampling or by doing an amniotic punction, and you do the genetic test and you find a mutation in the child, then if you want to prevent that the child will get the disease, then the only option is an abortion. However, we now see that there are many possibilities for doing what's called pre-implantation genetic testing. And that is always combined with IVF. And then you have a possibility to only induce a pregnancy of a child without the disease-causing mutation. And of course, then you know you will have a healthy child. And we now see that many of the parents that do have a recurrence risk for another child with NDI choose for this pre-implantation genetic testing mostly, and not so much prenatal testing, because of, they don't then have to do an abortion anymore. However, it should be noticed that many of that these pre-implantation genetic testing is not yet allowed in every country of the world. So if you want to do any of these tests, this should again be discussed in a multidisciplinary team, and then see what is the best options for these specific parents or patients that you are counseling at that moment. Next, please. So as I think in any process around guidelines, while looking at the literature and trying to set up these guidelines, you always encounter a lot of maybe already unanswered questions, but also new questions that you think there's much more research necessary to get an answer to these questions and come to an even better consensus statement or even guideline for NDI. And so we've done the same here, and we see what the research agenda is. So Elena also already mentioned that co-peptide measurements in children are not yet evidence. There's not yet evidence yet how to if this could be done. So we really have to see whether copeptin measurements can replace DDAVP or water deprivation tests in children. What we also not aware of so much is what are actually how does a pregnancy of females having NDI, what is the natural history, what are the complications in these females? There is only incidental cases, but we do not know really overall what are the pregnancy complications. Elena also mentioned about aging NDI patients, that they seem to have less polyuria, but actually we have never done a systematic study of the natural history in NDI, and this is really important also because it then gives you the answers how to do the best management for these patients. We also do not know what the long-term psychological outcomes of patients with NDI are. I myself have seen a lot of families with NDI during my career, and I encountered that many of the males with NDI do not have a partner. And so this is, of course, only something that I saw, but I've never seen actually what is the reason why they don't have that. So I think it's important to see what are the psychological outcomes of these patients and can we help them based on the knowledge. And also a very important one, because we know that very early genetic diagnosis gives the children a very good chance to have immediate management and therefore better outcomes. It's important question is, should we include NDI in a neonatal screening in future? And then, of course, maybe the most important question is, how do we actually come to a cure for NDI? And for this, a lot of fundamental research still needs to be done. There are some studies done, but several of the question is it possible to stimulate alternative pathways to allow aquaporin 2 to phosphorylate and then be transferred to the luminal membrane, so that you in fact sort of circumvent the AVPR2, the mutant AVPR2. Another question is, can trafficking of AVPR2 to the membrane be improved by pharmacological chaperone treatment? And I'll come back to that in a few slides from now. And maybe also, is gene therapy possible but also feasible for patients with NDI? So a lot of questions trying to find the right cure. And I just want to show you a few slides on what has been done on pharmacological chaperone treatment. So here you see again the basic defect in NDI is the fact that the AVPR2 receptor is not functional, or may even not be present in the basolateral membrane, and that then means that the whole pathway going finally to aquaporin 2 insertion at the apical membrane does not occur, and this means that water cannot be reabsorbed. Next slide, please. Yeah. So it looks as if you have the pointer, it doesn't work. Yeah. So what we have seen in many studies is that many of the AVPR2 mutants are in fact misfolded. And that means that these mutant AVPR2s are then retained in the endoplasmic reticulum of the cell. And by that retainment, it means that they are not present in the membrane, as you can see very nicely in this slide. And so AVP cannot be, it doesn't reach its receptor because the receptor is simply not in the membrane. And of course, then the whole pathway going to aquaporin 2 insertion in the luminal membrane doesn't take place. So people ask themselves the questions, are there small molecules that are able to actually improve the insertion of these, misfolded mutants to the membrane and then, in fact, rescue the defect? Next slide. And indeed, those molecules were found. Here, just maybe you can just go through the animation of this, and then you can see what happens with misfolding. Again, so no receptor, no AVPR2, so no water reabsorption. Next slide. So indeed, such molecules were found. In fact, it was shown that AVPR2 antagonists that are able to pass the membrane, so they are cell permeable, they then bind to these mutants that are retained in the endoplasmic reticulum, and by binding are actually able to finally bring them to the basolateral membrane. And once present there, we're able to indeed, that AVPRT then is bound to the receptor, and then the whole pathway going to aquaporin 2 insertion and water reabsorption takes place. This is all in cell models, I should mention. Next slide. Of course, this was very, very promising. So Daniel Bichet, already earlier mentioned, thought, well, if these V2 receptor antagonists, but maybe also V1 receptor antagonists that are almost the same, let us do a small clinical trial in patients with MDI. And they did. And as you can see in this very nice slide, indeed, those receptor antagonists were able to decrease urine volume and increase urine osmolality in these patients. However, next click, please. The problem was that these V1 receptor antagonists appeared to interfere with the cytochrome P45 metabolic pathway, which could lead to hepatic toxicity, and therefore the trial had to be stopped. And people then became very nervous about using any of these receptor antagonists in MDI patients until today. Next slide. Another interesting one is that AVPR2 agonists, so not antagonists, but agonists, have been shown again in cell models to be able to activate these AVPR2 mutants at their intracellular location. So even if the vasopressin receptor does not reach the membrane, it still stimulated the pathway and introduced aquaporin 2 in the luminal membrane, allowing water concentration. And you can see this in an animation in the next slide, how that works. So just keep clicking. Yeah. And then you see how it worked. Yeah. And this allows water concentration. So even if the V2 receptor doesn't reach the membrane, it still worked out very nicely in these cell models. However, until now, no animal studies or clinical trials in patients have been done with these V2R agonists, and we are really awaiting those kinds of study, hopefully that these agonists will not appear to be toxic and can help a lot of patients with MDI. And with that, I think, Elena, we want to stop and allow people to ask us questions.
Thank you, Nina, and also Eleanor, for the excellent talk. We do have a time constraint because but I think we should, now we have like 4 or 5 questions, and hopefully we can go through at least half of them. So for the first question is from Elsaidi. He asked about for infants with confirmed NDI, can renal formula, that is a low mineral formula, be used to provide nutrition while giving low renal solute low?
Yeah, I think the question is yes, mostly even in the normal formula, the sodium concentration is quite low. So mostly as long as they use the formula, even as a normal formula, this is not a problem. The problem starts when children start to eat, because then in each type of food we have salt, And then is a moment that kidney dietitian or renal dietitian need to be involved. For the formulas, I think the most important thing, these patients really have preference for water. They like to drink water and not so much milk. So this is the main problem with these patients, but they need to have calories to grow.
Thank you. So for Nina, there is a question on genetics, and in fact, that's also one of the questions in my mind is sometimes the genetics result come back to be a VUS. And in that situation, how would you advise us to work on? And in fact, we have one patient who actually present to our clinic with nephrogenic diabetes or some concentration defect after treatment for cancer with those drugs such as cisplatin. But the urine output is like 9 liters per day. Therefore, we check the genetic test and it comes back to be a VUS for the AVPR. So we were puzzled, and I think this happens with many centers, sometimes related to the interpretation, but sometimes it's a VUS by definition. So what was the thoughts on that?
Yeah, so it's really a very important question. I think in general, for any genetic disease, what did you do with the variants of unknown significance? That's what you mentioned, so the VUS. Well, I think, if you really have a very important reason to really suggest, you have many reasons to suggest that this is a congenital NDI, you should do anything to try to interpret this VUS better. So sometimes testing in family members could help, or even try to do a functional test of the pathogenic variant, which is possible. It's not very easy to do, but it's possible in the lab to see whether the variant does have any effect in a cell model, for instance. So you should really try this. In case of getting NDI after certain treatments, I think it's important to look into the literature whether we know that many drugs, and I mean lithium is one, but there are many more drugs who can induce a secondary or acquired NDI, and of course in those cases you will not find a AVPR2 defect. So I think it starts with how strong is your idea that this is a congenital NDI. If you're really absolutely sure, then look at all of the 3 genes, like I mentioned. And if you then still left with only the VUS in the AVPR2 gene, then go to do as much as you can, additional studies to see whether you can finally interpret the VUS. And if not, then probably you have to wait for a few years, because I'm pretty sure that in future we will be able to interpret all of the VUS that we have found.
Yes, thank you, Nina. One question for Eleanor is regarding the use of the dextrose solution in emergency management of NDI. I think it may not be comfortable for many of the general pediatricians as well as even the ICU doctor. So one of the attendees has this concern and asked for your guidance how to safely use the 5% dextrose alone without safely correcting without overcorrecting the sodium. And I have an extra question is regarding the quarter normal saline you mentioned, so 0.22%. I'm not sure if it's available in the Netherlands, but right now it's already obsolete in our pharmacy. So we have to do the dilution by ourselves if we do that, and it can also cause iatrogenic problems. So how do you solve all these concerns?
Yeah, we always get this question because it's really very much contradictory to what we learn in the medical school, that we should avoid a decrease in serum sodium quickly to avoid the neurological complications. So it's all true for most of the patients we see with hypertonic dehydration, but it's really not true for the NDI, as for the reasons I just have explained. So what you should do, you should start the rehydration with a normal rate. Just you calculate the IV fluid rate as you would do for any patients with without polyuria. So you should give the normal fluid amount, not the high fluid amount, because when they don't get any solutes, the diuresis would really decrease to almost normal level, and this is the trick actually. So that's the first thing to consider. But and the second main advice is to monitor. You just should measure serum sodium frequently. And I would not say what I do, I measure it actually in the beginning every hour or every 2 hours. And then when you see that it's going slowly, then you can, decrease your frequency of the measurement, and you just follow it every 3 hours or every 4 hours. And you can do it very easily by doing the capillary blood analysis, even in severely dehydrated patients. Another concern which is made, if you give so much glucose 5%, whether you will not have a hyperglycemia. Also, this should be monitored. It all can be done in the blood gas. And to be honest, I've never seen really severe hypoglycemia in patients getting 5% glucose solution because of the dehydration. So concerning the type of the solutions, now we also don't have the solution containing 0.2%. That's why we just use a glucose solution as we use in the neonates, for example. There we also frequently use a 5% glucose or dextrose. And but in some countries, like these recommendations are coming from US, probably they do have these solutions. But the main trick, don't administer sodium to this patient unless you really have a patient in shock and you have to think about blood pressure and maintaining the circulation. And the rest of the patient can be perfectly rehydrated with IV fluid containing glucose, or if they can drink water, the best thing for them is just drinking water, and they will rehydrate themselves if they are in the clinical condition allowing this.
Thank you. And one question is regarding the long-term outcome. So as pediatric nephrologists, we only see most of patients up to 18 or 21 years old, and quite common we receive questions from the family. How are they going to cope into their adulthood? Will they do better? Will they develop kidney failure? And we're already seeing it's quite hard to control their diets and therefore the urine output when they goes into the adolescent age, I think. So what's your experience, especially for Nina? You probably see a lot of families with NDI, and you may give us a better context of the adulthood outcomes for our patient counseling.
Yeah, well, like Elena mentioned, I think since we are better aware of NDI in, let's say, the last 10 to 15 years, children are seen very early, diagnosed very early, and then they already have a better outcome than many of the patients that I saw previously. So in the large group of patients that I saw that were diagnosed relatively late and had experienced a lot of dehydration.
Yes,
many of them do have cognitive problems, and
okay.
always also seen in this group is that many of them have these urinary dilatation problems. I even know of one of them who actually finally needed a kidney transplant, but this was decided not to do that anymore and died. But these are, again, examples of patients that were diagnosed quite late. And so I think, again, we need to do the natural history study for patients who are born nowadays, let's say in the last 10 years, and were diagnosed early, very early, and managed early, and how they will do. I think that would be more fair to look at them and see how the situation is now as compared to 20 or 30 years ago when it was far less. I know many of, for instance, many of the female carriers that I saw they said, I will never want a child with NDI because my brother has suffered such a lot and was doing so badly when he grew old. And I think that it might be different now again. So it's a difficult question to answer, but I hope and believe that many of these kids will do better than they used to do.
Thank you,
Elena,
Lina.
you want to add?
Yeah, I agree. I don't see adult patients here, but what I have seen several adolescents who became young adults or who are doing very well, who study well, whose kidney function is very well. But they always have to deal with this severe polyuria, even if they get low salt diet and even if they get medication, still the best patients still pee 5, 6, 7 liters per day. And this is really very annoying. So they have to get at night to pee, they drink. But I must say, these young adults, they manage well. They know if they go out and eat more sodium, then the next day or the next night they will pee more. So somehow they start to regulate it well. But this disease doesn't lead to mortality, but it's still a very severe disease causing a lot of morbidity and also a lot of psychological issues. And I do see patients having some concentrations problems, because I think this thirst feeling, there are several publications on thirst. And thirst is such a dominant feeling. It dominates everything if you are thirsty. And it causes really neurological disorder. We are constantly thirsty. So I think we take this into account and follow this patient using the registries, and then we will know more. And hopefully there will be better treatments allowing us to really to improve the condition of these patients.
Okay, thank you, both of you, and thank you for the huge and significant effort in publishing this important guidance. I think it's really helpful for clinicians and also pediatric nephrologists like us. So thank you so much for the efforts, and also thank you for joining us at the IBNA webinar today. So see you. Good night.
Thank you very much.
Bye-bye. Bye-bye.
Bye-bye.